Good afternoon, everyone. Thank you, Panos, for inviting me. So as Panos mentioned, I'm a professor in the robotics group at King's in the same department with Panos. And I'm a co-investigator on a project that was funded just about 2 years ago by EPSRC that's looking at the idea of using AI and decision support to help patients manage chronic conditions. And for this project, we selected secondary stroke prevention as the case study. So my background is in AI and robotics. I don't know really much about stroke. Everything I know about stroke is probably encapsulated in these slides. So limit the kinds of questions you ask me. So let's see. The motivation for the project was generally around the idea that we want patients to be able to manage their own care on a day-to-day basis. And there have been studies that have shown that the more patients are involved in sort of understanding the impact of daily decisions that they make on their health, the better they are at maintaining a better health in general. So we wanted to sort of build on that kind of result. And the idea is that if we use the kinds of commercial wellness sensors that are available on the market today and use them in conjunction with some decision support technologies that are being developed within the field of AI, maybe we can help people get a better sense of the things that they do on a day-to-day basis and how those can help, how that information can help them make decisions about general things that they do in order to maintain their health. So in general, the wellness sensor data that is available today on things like a Fitbit or your walking meter and things on your phones, they're independently manufactured and they don't connect to each other. So if you have a blood pressure monitor and a heart rate monitor manufactured by two different companies, you can look at their data separately, but you can't look at them together. Same thing with your activity monitor, etc. So there's one problem right there. Another problem is that none of that data is connected to your electronic health record. And a third problem is that none of that is connected to whatever treatment plan you work out with your GP or consultant. So the idea behind the Consult project was to try to put all of these three things together. And an interesting aside, listening to some of the talks earlier this afternoon, one of the things that we found when we started sort of conceiving this project, which was about 3.5 years ago, it was kind of like the companies producing the wellness sensors didn't quite realize the value of their data. So you used to be able to, if you had bought a Fitbit, you used to be able to just for free connect to the raw data stream that the Fitbit was generating. Now you can't do that. And in fact, in the timeline between when we first conceived of the project and wrote the application and actually got the funding, that door had closed. So none of the data that we had planned for the project that was free anymore. So some of the time we spent on the first year of the project was really trying to figure out, well, how can we get hold of the data without having to pay for it? And that has meant, in the end, that we've been seeking collaborations directly with the like development teams of different companies, and we've managed to do that with 3 companies to be able to get the access to the data that we need for the project. So the idea, as I said, is that what we want to be able to do is combine wellness sensor data with intelligent decision support and put together the electronic health record and information from the general practitioner or the consultant, whatever healthcare professionals are working with the patient to maintain their well-being. And also in conjunction with the, at least in the UK, with the NHS guidelines. So often in the doctor's office or in hospital, they'll hand patients various brochures, or they'll say, here are the guidelines. And if you've been in a situation where you've been handed those, you probably like stick them in your bag and you get home and forget that you ever had them. And so what we wanted to be able to do was put that information also as part of this system, so that at the point at which the information in those pamphlets are useful, then it's provided to you, instead of having to remember where you put it. So here's a big picture of what we've been looking at for Consult. So the idea is that, the patient's at home, they have their wellness sensors, they have some kind of mobile device, whether it's a phone or a tablet or even could be a desktop. And they have some questions about, well, should I go for a walk today? Should I keep eating this thing? Is it helping or hurting my blood pressure? These kinds of things. Maybe it's a question that's really, it's not a doesn't seem to be a life-threatening emergency, so probably I don't need to go to the A&E, and I maybe don't need to call my GP, but I'm still curious about it, and this is where the idea of consult comes in. And so, once you use consult, the vision is that then everybody's happy and healthy, right? The bulk of our project team has expertise in data management and data-backed decision-making within AI, artificial intelligence. And so, as I mentioned, the idea is to put together these data from multiple different sources, so wellness sensors, electronic health records, NHS guidelines, and treatment plans. And one of the things that we've found out, one of the key parts of this project, which is mentioned on the bottom side, is that we've been co-designing the system along with healthcare professionals. And in fact, we have a GP who's part of our project team who has recently retired but was a practicing GP with NHS for 30 years. So he's got lots of experience and lots of expertise about what are some of the practical issues that GPs face. And if we're designing something for GPs to be using, what are the kinds of things that we need to be considering? And one of the things that the healthcare professionals we've been working with have pointed out is that the opportunity for them to look at the data that's collected over a longer period of time is really significant for them because of things like taking blood pressure when people come into clinic and there's a white coat effect, and it's much more helpful for them to be able to see, well, here's what the blood pressure is in the office, but then over the last 2 weeks, here's what the different readings were, and to be able to see that in an integrated way is very helpful for them. From an AI technology standpoint, we've been looking at two primary technologies. One is called computational argumentation, which I'll talk about both of these in a minute, and the other is called data provenance. The key reason to look at computational argumentation is it's a structured way of being able to make decisions by using data or evidence and potentially finding conflicts in that evidence and trying to figure out how do you make decisions when there are conflicts. The reason to look at data provenance is it also provides structured ways of being able to track where information comes from. So if you're looking at a decision support system that's built on information coming from a number of different sources, and you could be having, say, information from like several different treatment plans. So one of the things that is often a factor is patients that have comorbidities. So maybe somebody's had a stroke, but they also have diabetes, or they also have heart disease, and they're getting treatment plans from different people, different specialists to manage these things. So how do all of those things interconnect? So data provenance will help you track the different pieces of information that you've gotten. Where did it come from? When was it added? When did you know about these different things? And that's part of the decision support system. So it's a kind of quick outline of the talk. So I'm going to talk about our development of our case study, which, as I mentioned, is secondary stroke prevention. I'll give you a little bit of background on the technology. I could go into a lot more detail on the technology if you wanted to, but I don't think you want to. And then I'll tell you where we stand with the timeline of the project, which is we're leading up to our big sort of system evaluation over the next 6 months. One of the things that I'll just point out is that within AI, one of the hot topics these days is something called explanation. So people have been finding that with the growth and popularity of machine learning kinds of decision making, machine learning techniques tend to be a black box where you put a bunch of data in, you get some answer out, and nobody really understands what's that structure that has created that decision. So a new trend is to be able to provide explanation to users that say, well, this black box machine learner has recommended a particular thing, and this is why. These are the things that went in, and this is why the decision is the way it is. And what we found is that these particular AI techniques are very conducive to providing explanation in a natural way. And so that's one of the benefits of this project. So we started with a focus group in December 2017 where we had 24 stakeholders, so 14 were stroke survivors, 11 healthcare professionals, and 9 researchers. And so I'm just going to quickly go over some of the feedback that we got from this focus group. And we presented to the focus group our general idea. So that sort of cartoon I showed you a couple slides ago and the general concept. And we started to gather information from people who are dealing with secondary stroke prevention on a daily basis to find out from them what are the kinds of things that would be useful for them, what are the kind of problems that they face, and what are ways in which that we might be able to help them. And so some of the feedback that we got is listed here. So for example, whatever system we build, and our aim is to have something that's going to be fitting on a, well, probably it will fit on a phone, but we're working with a tablet that's a bit bigger format so that we can put more useful information in it. But so this app or this system should be personalized and tailored to the individual patient. So again, coming back to some of the commercial wellness sensors that you get, you can get a blood pressure monitor that will let you take your blood pressure and give you some graphs on your phone, but it's not going to tell you anything about you. It will just say, based on NHS guidelines, you fall into this category. I think it's one of 5 different categories. It's not going to tell you much about you personally. And so they want to be able to say, well, if we have an app that's built specifically for this kind of care, then can we have this tailored to our own particular needs and our treatment plan? One of the things that the healthcare professionals pointed out is that every patient may have different thresholds for pain or for activity, and so might require different kinds of personalized advice. And so that's one of the things that we're putting into the system. Another thing is that systems should provide real-time monitoring and information on patient risk factors. So for example, one of the popular things people look at is, here's my risk of, say, heart disease. If I quit smoking, here's how the risk is reduced. Those kinds of things. And so can we talk about risk within the system and then be able to share that with people in a way that they can understand? So that's, again, touches on the aspect of risk. The system should also enhance communication with healthcare professionals. So in general, GPs don't have a lot of time, even if you're a patient that has a chronic condition and need to frequently come or regularly come see, go to a clinic. Each individual doctor doesn't have that much time to spend with each patient. And so can we encapsulate what is the information that the doctor wants to know and provide it to them in some way that will be really useful? And this was one of the main pieces of information that we've taken away, in the sense that looking at what we were thinking of when we started conceiving of the project versus what the practical reality is, we thought, that doctors would be happy to have an interface where they could click through and see a bunch of things and like balance some, what if I tried this with the, recommended this to the patient versus that. Well, unfortunately, the GPs don't have time to look through that, and what they really want is one sheet of paper that they can look at that says, here's what the story is with this patient for the last 3 months since you saw them. And so that's the kind of thing that we're putting together. The system should be able to support 2 different types of users. And if we're going to make gross generalizations about the way people use their apps, there are really 2 types of people. There are passive users who don't want to actually go into the system, but might want to see a notification if there's something going on that they need to pay attention to. And then there are active users, the ones who are checking it all the time. And so can we build a system that will support both types of users? And that's what we're doing. The system should monitor and support physical, emotional, and social aspects of self-management. So we're definitely working on physical and emotional aspects. At the moment, we're not doing any social aspects. We've talked about the idea of integrating into some kinds of social networks. With GDPR, you get into a lot of issues with that, and so we've sort of tucked that one aside for now. We kind of have enough on our plates without thinking about that. And then the last thing is that the system should provide useful summary of the patient's, sorry for the typo there, information for healthcare professionals, which ties in with the one at the top. So we looked at some different scenarios. I mentioned that understanding risk was one of the things that people were interested in. And so we wanted to be able to make recommendations based on known models of risk. And this is, I don't know if it's a little bit hard to see, but this is one of the things that people have one of the visualizations that has been shown to be understandable by patients. So the idea is that probably can't see because it's not a very good print here, but this is least likely and this is most likely. And what this says is that your current risk here of having whatever the particular problem is quite high if this is most likely. But if you undergo the treatment, then your risk will move down to here. And being able to compare those two levels of risk is something that most patients are able to understand well. And so developing visualizations and including those in our system are one of the things that we're doing. As I mentioned, we're going to include NHS guidelines to provide explanations for people at the time at which we feel they need the explanation. Then I'll explain in a few minutes how we know it's the time to give them that, but also to use those guidelines as the basis for doing the kind of reasoning that we're doing in terms of picking out what decisions we're making at a given time about the actions that somebody might take. Patients want to be able to visualize their sensor information, so even if they're still using a commercial wellness sensor, it will be nice to have all of the data aggregated in one place so they don't have to keep opening different apps made by different companies to look at different metrics. And also to be able to look at that data in conjunction with the recommendations that the integrated system is providing, which we are doing. And then providing alerts where appropriate. We are providing some alerts. For the most part, the system that we're building is not designed to be like something that recognizes an emergency at the moment, and so it has some limitations, but it will look at data, say, over the last week and say, well, we've noticed that this week your blood pressure is higher than it has been, and so that kind of a notification is where we're heading. So here's a case study example, and this is a screenshot of our prototype system at the moment. So our example here is a patient called Bob. Bob's a 66-year-old stroke survivor. He monitors his well-being using commercial sensors, and in our vision, he uses Consult to manage his self-care. Consult comprises an interactive dashboard and a chatbot, so I'll show you some screenshots of how this has been developed. So using the Consult dashboard, Bob can see his latest sensor data and trends. So this is showing his heart rhythm or ECG. So that's and the visualization here is meant to be quite simple snapshot. You can drill down and get more detailed information if you want it, but most of the time the feedback that we've gotten is that patients just want to know, are things okay or should I be worrying? And so what this shows is that if the things are within that green band, then things are okay. If they move out to the amber band, then maybe some attention should be paid to what's going on, and certainly in the red band, then you need to call your GP. The dashboard can alert Bob to any important data, such as elevated blood pressure. So the dashboard has these different icons saying what's been monitored. So this is blood pressure, heart rate, ECG, pain, and mood. These are both self-reported, whereas the top three are collected by the wellness sensors. And these would be all green if everything was good. If there's something that needs attention, then like this, the blood pressure is amber. If it was in a more problematic state, it would be red. And so clicking on this would open up this screen, which sort of says, well, this is the standard NHS chart for blood pressure, and it says, your blood pressure is in this amber zone, and it should be in the green zone. So you might want to contact your GP, or let's take a look at it over the next time period before we worry too much about it. And one of the things that we're quite conscious of is by giving patients access to more data about what's going on day to day is we want to not increase the number of times patients are calling their GP, because then GPs will hate us. And so what we really want to do is increase the comfort level that patients have with how things are going and make them feel more in control of managing their situation. So it's a fine line. Too much information can also be a bad thing. So this is one of the things that we will be teasing out as we move to our user study phase this summer. So I mentioned we also have a chatbot as part of the system. This is where we focus on the explanation thing. So this is one of the sort of case studies we've been looking at. So Bob can interact with the chatbot when he has a problem or even when he just wants to chat. So in this example, he's experiencing back pain. So he opens up the chatbot. Chatbot says, "What can I help you with?" And Bob says, "Symptom." Chatbot says, "What symptom?" Bob says, "Back pain." And I should mention that we're working on the interface so that the way this works is that Bob will click on some buttons rather than typing free text, which gives us an easier way of handling the input from the user and also avoids misunderstanding about things that the patient is trying to say. We could see going forward to a more natural way of doing interaction with the patient, but our focus is more on the AI recommendation part of the back end of the system and not so much on what the chat interface is, and so a follow-on project could look at that. So the chatbot provides information. So the chatbot says it's recommended that you take ibuprofen. Would you like more details? The patient can say yes or no. In this case, Bob says yes. And so given your medical history and that ibuprofen helps with back pain, then ibuprofen is recommended. And what will happen in the system is it'll record that it recommended ibuprofen. And then it'll come back the next day and say, "Hey, Bob, did you take the ibuprofen? Is it helping?" If it's not helping, then it might recommend something else. Okay? And because the system has access to Bob's electronic health record, it also knows what other medication it's taking. So it can be careful to say, I don't recommend, say, paracetamol because that might conflict with a particular thing you're taking, so we recommend ibuprofen instead. So it's a little bit, it's well informed in terms of what Bob's particular situation is. So the consult system can also monitor Bob's mood. One of the things that feedback we got from the healthcare professionals is that with patients with chronic conditions, depression is quite prevalent, and so being able to monitor how Bob is feeling is useful. And we have two ways of doing that. So one is using this idea of a mood board, which is something that people have been using in research a fair amount lately. And the idea is that you have this grid of photographs, and so Bob will get asked periodically, how are you feeling? And Bob can volunteer to answer this more than once a day, but it's not going to ask him more than once a day unless he wants to go to it so that he's not being continually pestered. Well, how are you feeling now? So the mood board is the idea that you find a picture that represents, your mood at the moment, rather than saying, on a scale of 1 to 5, are you happy or not happy, kind of thing. Apparently, does better at capturing moods. And these have been validated instruments, so that will help capture more informative pictures of people's moods besides just happy and sad. So that's the mood board, and then there's also a depression screening, which is provided by the NHS, and we can deliver that through the chatbot. And so we will do that as part of our user study. We'll do it once a week. To check in, and it's not something that would be done that frequently, but it provides another way of sort of monitoring the patient's mood. So based on feedback from the focus group, we will be monitoring these 5 different health parameters and providing ways to either show the data directly from the sensor, as I illustrated, or showing the chatbot, which lets the patient ask questions and also lets the patient ask questions about aspects of the data that's shown on the charts. So I'm going to give you a quick rundown of the technology development. I mentioned the input data, which is coming from the sensors, either passively through wellness sensors or actively through things that Bob is doing, like clicking on buttons in the mood board. To that, we apply some various data mining, which techniques we apply depend on what the data is. So some data like mood, we're not going to have that many instances of, but other data like heart rate, we're going to have lots and lots of instances, so we need to be doing some summarization. And so that data mining feeds into our reasoning engine, which is driven using argumentation and data provenance. And then is used as all of this is used as the back end to our user interface, which is the screens I've just showed you. So I'll give you kind of a quick overview of what these technologies are. As I mentioned, I can go into a lot of detail about each of them, but in the interest of time and at the end of the day, I'm not going to do that. So these are the 3 wellness sensors that we've selected. Garmin, which provides like a wrist, like a watch kind of thing with a heart rate monitor. Withings, which has a blood pressure monitor, which used to be Withings, then was Nokia, and now is Withings again. So there's some history there. And then something called the Vital Patch, which is a device that it's something that sticks onto you and will track your heart rhythm. And so we've been collaborating with the tech people in each of these 3 companies to be able to get access to the data that we need to feed it directly into our system. So the data is collected on these different types of properties, so heart rate, blood pressure, heart rhythm, and activity, things directly from the users. And the data is mined for patterns, which produce the data visualizations, like I had showed you an example of, and then for arguments that get fed into the reasoning engine, which can be used to interact with the chatbot. So I mentioned the idea of computational argumentation. This is a formal reasoning method that has its history in AI and in philosophy, and started by looking at how people reason and make decisions. And the idea is that when you make decisions or you draw conclusions about things, people tend to gather evidence for and against particular conclusions. So I should take a walk, I shouldn't take a walk, what are all the reasons why I should take a walk, what are all the reasons why I shouldn't take a walk, put that all together in your head and make a decision for or against taking a walk, right? So the nice thing about working with argumentation in an AI application is that it has a solid foundation in formal logic, so that there are proofs that exist to validate and verify that certain kinds of decisions are taking into account the different aspects of the reasoning and evidence that's already in the system. So there are a number of different details which I don't want to go into, but we have ways of looking at what are called argumentation semantics, which show different methods for how you would put together conflicting information and how that could be weighted in one way or another. There's an area called argument schemes, which looks at ways in which data from different sources or data being used in different contexts is used differently. So the classic example of that is a random person on the street gives you directions. Would you rely on that more than, say, a police officer giving you directions? Because a police officer is wearing a uniform and representing some kind of authority, your interaction with them might be different than your interaction with a random person. And that kind of flavored interaction is captured in argument schemes. And then argumentation-based dialogue, which is a way of structuring how people and agents, software agents or robots can interact with the data that's structured as an argument database. And that's going to be that is the underlying basis of our chatbot. So here's a very simple example of argumentation. So it's a decision, do I have to go to work? Well, I have some evidence that says it's a weekday. I have evidence that says I have a job. And then I have a rule in my system which says if it's a weekday and I have a job, then I have to go to work. And so my conclusion is I have to go to work. Okay, so it's a trivial example, but you could imagine putting some other things in there like, I have a fever, so maybe that's another piece of evidence. And then maybe you have another rule that says if I have a fever, then I shouldn't go to work regardless of these things, right? Or it might be that it's a bank holiday, so it's still a weekday and I still have a job, but it's a bank holiday. So those are things where you'd end up having further evidence that would negate the conclusion. And so argumentation helps you sort all of that out. We've been using argumentation for quite a while in some of the research that I've been doing along with some of the other colleagues on the consult team. We've tested it with users and been able to show that the kind of reasoning that we come out with and the structured way in which we interact with users by showing them how the pieces of evidence weigh for and against certain conclusions have shown that such reasoning does become explainable and users are willing to accept the explanation. So that's a quite powerful concept as we move forward applying this in the domain of consult. Second technology that I'll mention is data provenance. So the idea is essentially a record describing people, institutions, entities, objects, activities that are involved in producing, influencing, or delivering a piece of data or a thing in the world. It's a classic definition of what data provenance is. And as you're using a system that reasons with data from a lot of different sources, you may need to be able to track that information. Okay? And so one can build what's called a provenance graph, which captures all of this information. And so that will help figure out which pieces of data led to different decisions. So this is not about making the decisions. Computational argumentation is about making the decisions, but this is about helping keep track of what information led to those decisions. And so it's a very helpful way of being able to link the two together. The last technology that I wanted to mention was this notion of argumentation-based dialogue. It stems out of the idea of building or organizing data using argumentation, where things are organized into rules and evidence and conclusions. But once you have that construct, what do you do with it? Well, usually you want to use it to make decisions, and if you want to make decisions with other people, or you want two software systems or two robots, or robots and people to make decisions together, then argumentation-based dialogue becomes a good way of doing that. And so some of the ways in which argumentation-based dialogue has been used that we are using within the Consult project is to resolve conflicts, to reach agreement, and to convey explanation. Argumentation dialogue has a number of specific what are called dialogue types. These are a few of them. There are many more, but the ones that are really pertinent to here are something called persuasion. So if you imagine that you have the chatbot, which is essentially a software agent that's communicating with the patient, and the chatbot says you should take a walk, and the patient says, I don't want to take a walk. Now we have this conflicting belief, and so if the consult system is been told from the treatment plan from the GP that the patient really should be walking a certain number of steps a day, and the patient isn't doing that, then the onus is on the system to try to persuade the patient to take the walk. So maybe the system can come up with some, maybe there's some incentives built in that say, well, you've only done 5,000 steps today and you're supposed to be doing 8,000. Some different ways of basically informing the patient that they could improve their overall well-being if they follow some of the things. So persuasion dialogue is a structured way of being able to resolve conflict. Information seeking is about lack of knowledge, so this is directly where the explanation comes in. So maybe as part of the persuasion dialogue, the system says to the patient, you should take a walk, and the patient says, well, why should I take a walk? I don't understand why I need to take a walk. I don't have any information that shows me why I should take a walk. And then the system can pull out from NHS guidelines to say, well, you should be taking so many steps a day given your age and your weight and various other factors about your health. And so that would feed into this information seeking dialogue. The last kind of dialogue is called an inquiry dialogue, which is when both entities, the patient and the system, don't have a specific knowledge or evidence for or against a particular decision, and so together they go search for it. We're not sure yet whether, while we can conceptually think of ways to use that in our system, we're not sure whether we'll be able to do it from a practical standpoint, so this part is still under research. There's some formality that defines how different things happen within a dialogue and provides a nice structure for human interaction with the AI system. I'm not going to go into the details of our system architecture, but there's boxes and data is passed around and it all works great. So the last thing I wanted to talk about was our system evaluation. We have a user study planned for summer 2019. At the moment, our ethics approval is pending. We are also in the process of getting our software infrastructure. Well, we have a prototype demo system running at the moment. In order to be able to handle NHS patient data, we have to go through a bunch of other approvals, which are sort of akin to but not part of the ethics approval, so that is also still pending. Our plan is to recruit patients in two groups, because we're going to run sequentially one group and then a second group, and we'll do a comparative within subject study using to assess the performance, so how well people use the system and how well they monitor their health, and then general acceptance, do they like it or not like the system. And we'll give them, each patient will have a week with the chatbot and a week without the chatbot, and it'll be mixed up, so some will start with and some will start without, and we'll evaluate comparatively how they do with the system. So the current state, we have a working demonstration that we've used in a couple of different conferences. In fact, we won a Best Demo Prize at a conference in December, and we'll be demonstrating again in May. And then the prototype system, as I mentioned, will be evaluated in a user study with patients this summer. The consult team is a large team of investigators and postdocs, and so a lot of the work is done by them and not by me. So I want to just acknowledge them. And of course, EPSRC is the funder. And we have some publications out if people are interested. And I'm happy to answer some questions. We have a website also. I think I'm just about right on time. So
thank you very much.
Thank you.
Thanks for the very interesting talk. Any questions or comments from the audience? I have one. I was going to ask, I'm curious, so the argumentation work, if I understand correctly, apart from making a decision, is trying to explain the decision to the user, patient, or user perhaps. I'm curious, what about healthcare expert providers, are they convinced about letting the system itself make a decision or a recommendation for the patients? To what extent this is a common, how acceptable is that? And if you've seen this with your case study where you asked healthcare practitioners.
Right. So that's a good question. So the system as we have it is not going to make decisions that a GP would make. So it's not going to replace the GP. It's going to help patients fulfill the treatment plan that the GP has given them.
Okay.
So it's not meant to, provide answers to questions that the GP would be the one answering, but rather if the GP says, gives you like, these are the things that you should be doing,
okay,
how do you make sure that the patient is adhering to those and fulfilling the things that they're supposed to be doing? So, for example, there'll be a reminder that says, have you taken your medication today? This is what's in your health record, what you should be taking.
So there will be sort of tailored to the recommendations by the GP for a particular patient or user.
Right.
Okay.
Yeah.
Okay. Yeah, interesting. Okay. Any other questions? Yes.
Yes.
Well, thank you very much for this, I would say, fascinating talk. But I think that until now we have seen what I could say the positive aspect of these new technologies. And I think that maybe one dimension is missing, and even in our meeting, related to the socio-economical, educational impact of these new technologies. Because I am just taking the case of patients. I have been patient. Many of you have been patient, And to some extent, you could consider that such devices could make people hypochondriac. Do you understand what hypochondriac is?
Yes.
Okay.
Yes.
And don't you think that the behavior for one person, and for one person with respect to his surrounding, with respect to his physician, and many other persons will be totally perturbed or improved. But I'm not sure what will be the result.
Right. So, yes, I agree with you, and that's why one of the things I mentioned earlier is that sometimes too much information can be a bad thing. And one of the things that we're hearing from patients is things like the number of steps that they're supposed to be taking, for example. Because they don't look at or monitor that data, they don't realize that they're not complying. And so that's a case where the information will help them comply. Information about blood pressure, we might find that that is something that on a daily basis is not helpful to give to the patient, but it's helpful to collect so that when the patients go to the clinic, the GP can say, well, can look and see, here's where the blood pressure was at home over the last 2 weeks, rather than just the 10 minutes in the consultation. So part of our user study will be to help figure out where these thresholds are. So, but yeah, I mean, we definitely are conscious that we don't want to be increasing the anxiety of the patient, and we don't want to be increasing the number of occasions in which a patient will contact their healthcare professionals. It's supposed to, the aim is to reduce that interaction so that the number of times a patient contacts are really much more about the times when the patient really needs help. So we'll see what happens. But yes, we are well aware that that might be a bad thing.
We will see what happens. I think
Yes.
that we have not to ask the question if it will happen.
Yes.
It will happen.
Yeah.
What we don't know is when it will happen.
Yes, yeah. I think one of the things that we're also conscious of is that in the very early stages of developing something like this, it would be at least 10 years before something was commercially available. And so if we look at the aging population, the people who are, 10 years younger now would be the ones who would be maybe using it in the future, and the comfort level at dealing with mobile technology and social networks and that kind of thing is very different even from my age to my kids' age. So, as they age into the need for something like this, then the norms will have changed. And so we're trying to maybe predict a little bit about where that will be going. So,
Yes.
Hi, so I know quite a bit about the study through Mark Ashworth and
yeah.
Fazza, but I think it's absolutely right to take this technology forward, and a lot of it's being used in primary care, not with the remote monitoring, but certainly in terms of guidelines and pop-ups on screens and other things. But I guess it's whether you're really dealing with stroke or just dealing with an aging population, because you might say that you might not be as technology proficient as your kids, but if you've had a stroke, and the slides I showed, a third will get cognitive decline within 5 years, or depression, or other things. So even if you're super efficient, like the 20-year-olds in the room, if they have their stroke, they won't be. So I guess it's whether the technology is fit for, it'll be fit for a certain portion of the stroke survivors, but I suppose it's knowing which ones, so you can stratify by those most likely to uptake the technology.
Yes.
Have you got any data on that yet?
So I don't have any with me now, but as a group, we have been looking at, what's the, so we've been looking at the socioeconomic demographic, because of the way this project is funding, focusing on the UK, but what can we expect in terms of the number of patients that would be able to use a system like this? And, as I mentioned at the beginning, we're looking at, in a broader sense, using this kind of technology for helping patients manage chronic conditions. So we're also looking at patients with diabetes. So I think that I agree that there will be patients whose physical limitations mean that they can't work with a tablet at all. And we'll have patients who, for various economic or education reasons, have trouble interacting with the system. And so we're not saying we're going to come up with a solution that works for everybody, but I think there will unfortunately be enough people in the population that would be able to use it, that it would be helpful. So,
Okay. Thank you very much again.
thank you.